Yes.
Fran Henry from the forum. I'm interested in, of these models that you're offering, since this is a forum that is science-based and evidence, certainly looking for evidence, if you would pick from the models you've discussed, the ones that you feel are the best for producing the kind of evidence that's needed to move this field forward?
That's the first and best question I knew I would have. I am going to rock into I'm going to probably come down on the public health prevention intervention, the primary, secondary, tertiary prevention model is the one at the moment that I'm going to say I think has because data supports how actions occur and it embraces the the ecological model well. So there. What's nice about it is it has the data to support the actions that occur or should. Oh, I'm sorry. Pardon me.
That's okay. I'm Sue Bogner, Institute for the Study of Human Error, LLC. And I want to raise an issue that I don't see addressed anywhere here. It's a form of abuse, but it's well intended, and that is over-medication of the elderly. We may all know, I certainly know many people who take upwards of 15 pills a day. And they go to a physician, they have a problem. The physician, well intended, prescribes another pill. So it goes into this. I heard earlier talking about medication changing quality, changing lifestyle. It's easier to take a pill than to change lifestyle. But this affects the quality of life of the people and impairs the cognitive functioning. And some people may end up in nursing home or with dementia, which it is not inherent in the individual. It's expected of the elderly, instead of looking at why it happens in medication. And another aspect of medication is it had been used until fairly recent years. Meds had been tested on 32-year-old white males.
Absolutely.
That does not affect us. Maybe some of us, but not most of us. But those same pills that worked on 32-year-old white males are given to 85-year-old, 100-pound women. So we have, I think, a whole problem here. It costs money. It affects quality of life. So I just like to raise the issue.
Thank you very much. I would think the docs in the room who prescribe these things could be the best people to respond.
Here, here.
Okay, good. Good. We have all known this for a long time that the rates for body absorption is very, very different for older adults than they are for younger populations. Thank you very much. You're absolutely right. What am I going to do about it?
It doesn't fit any place here, so we know it exists. We know it affects quality of life. We know it costs money, but it continues.
You know, I would argue that it does fit, as a matter of fact, and I'll just use quickly the ecologic model. It affects both the quality of life of individuals, the family interactions that individuals will have, agencies that have to interface with older adults, and our larger treatment of how we move markets around to compensate for what we're prescribing.
No, I'm aware it fits there. I just don't see it listed as a form of abuse.
I don't typically have anybody quiet in my class, so it's amazing. Yes. Oh, okay.
Two things. One, the questioner is right. If you look at, I think she was talking not so much if it fits the theory, but if we measured it, and at least it's not frequently measured, so that's a shortcoming in our research. Pam teased me a little bit about the theory and theoretical models in the beginning, because at one point I said, stop talking about models and let's just count. That's the theory, is when we're talking about prevalence. But the reason I said that is we had gone back and forth about definitions for about 6 years and could never actually count. So we didn't count. So, but I see the same problem again with 14 or 17 different theories. You know, and you had the first question, okay, which one has the best data? But if I had to put it to you, which one would you pick for, and don't say ecological model because we all agree, but which one would you pick, that's the guiding structure, for community residing non-demented elder abuse and versus institutional? I don't think the power explosion, feel bad, reconstruct, that's not going to fit it for most cases. So I'm going to force you into a corner and pick a model.
She did already. I said public health model.
Yeah, but I'm asking for one versus the other, and specifically, how would you apply it differently?
For one model versus the other?
No, one type of abuse versus the other, and trying to do that theme of there's two different.
Okay. Oh, gosh. One abuse versus the other. And by this you mean pick an abuse for an example, Ron? Okay. They're both individual level approaches. I think that the model I would pick for approaching elder mistreatment in the community still resides somewhere with some of the, can I have more than one? You make me pick one? Okay, two. Still resides somewhere with, so in the community, I still think where it sort of resides is cumulative inequality, because I think it's an exchange relationship of some kind. And I still love ethics of care, which is how we treat individuals. So I get at the level of the individual. Now, facilities. So you set me up. That's harder, too. And we both have worked in both domains of that. There, I think it is a prevention model, because I believe if we are saying in the main, in some types of abuse, not all, that the carers are the folks who are doing the abuse in facilities, and that's not always the case, as you know, then I think we need to find out more about preventive measures for those individuals, as well as understanding their economic situations that may enhance their ability or their ability to perpetrate. Because I think a lot of those individuals, and I've had this discussion with you, are abusing because they are not trained, they are frustrated, and they have other home situations that may cause that abuse. So I think we have not touched that very well, although I think Carl Pilmer has done some work in that domain. So I'll say that one will be for facility level. Did that start it? I can talk with you back when we walk back again, like we did several years ago.
I think the dimension shouldn't really be institutions and communities, because in many developing countries, less than 1% of the seriously disabled elderly are in institutions. I think the dimension is what you said before, those who are severely demented and therefore really incapable of expressing their own desires, those who are mildly demented and have some degree of capacity, and those who aren't demented at all and have full capacity of making their own decisions. And I think that's, and in institutions, it's not only the demented in the institutions, right. Also have physical illnesses. So you have some in institutions who aren't demented, who are certainly capable of making rational decisions. And I think that's a much more important, so that make 6 groups, in the institutions, the 3 levels of dementia or non-dementia, and in the community. And then there, I think that would be a much more reasonable way of thinking of what types of approaches are important. Because clearly for those who are seriously demented, you've got to use a different approach, and you have to think about how to identify and address it, because you can't ask the person. They're really unable to clarify. So your way of measuring and monitoring is going to be very different, and the types of approaches you have to use to decide what's best to do, you can't depend on them to provide that information, whereas if the person's fully cognate, you do. And so I think you have to use very different models, and those are the dimensions, as opposed to institution and non-institution.
Yes.
Yes, my name is Larry Minix with Leading Age. Last summer, the White House had big confab on financial abuse of seniors, and something we have a lot of interest in. I'm trying to sort out in my mind, amongst all these theories, the difference between a risk factor, an indicator, and an actual cause of abuse. My grandmother used to say, and it's not original to her, I don't believe, money is the root of all evil. How much elder abuse, the cause is greed among the people that get hold of these folks and want to get their money? How much of it would be pressures that families are under financially that cause assets or incomes to be, people to be taken advantage of? How much is caused by mental illness? I can't imagine caregiver stress is something that would be ignored, but I've personally known of a lot of people that have gotten into abusive situations because of the tinderbox of caregiver stress. What are the, would you say, the 3 or 4 root causes of elder violence and abuse? How, if we looked at 2 or 3 things that are the major causes, how would you boil those down?
Well, I think one of the issues is that individuals are being, I think I'll go back to what Ron has said, one of the individuals live in some of isolation. And so some of the isolating effects of individuals, both proximal to individuals, but also if individuals are proximal to individuals but are isolated in their own homes or in a facility, that is a problem that makes a situation fairly ripe for that particular issue. I think at a macro, in a sort of macro way, both macro and micro, your issue of greed or wanting something somebody has, as I was telling a group of students yesterday, drives issues of exploitation, whether it's drugs, whether it's power, whether it's the drugs that an individual has, whether it's the money they have. Those are certainly human wanting something somebody else has would be another piece at the root of that. More eloquent and elegant understandings of the nature of abuse. I think lumping all abuse together is difficult to do. I think what we know is these sort of nuanced types of abuse are where we need to go and think about, because the interventions are different based on what kind there is. Some of the work from the folks at the University of Virginia have done some work on hybrid kinds of financial abuse versus pure financial abuse, and I think they're getting at something terribly important there, not only the issues of the dementia that we may need to think about when we start talking about interventions and approaches for those folks, but what are the nuances of types of abuse? So,
one final question. There's so much emphasis in the states today about curbing healthcare cost inflation. Yes. Unless I missed it, is there any data that says elder abuse rolls into the healthcare delivery system and costs this amount of money, and if we address it, it'll help with the cost of healthcare among seniors?
yes, some work on that has been done by some authors. Folks in Utah did some work on costs. I'm blanking on somebody else, but I also know I have too.
Okay, thank you.
Pam, we need to move on to the next session, but I think one thing for us to think about in terms of what helps us move forward is that sometimes some theoretical frameworks are really useful on the prevention side. In other words, some of the risk factors, etiological factors, that you need to address those in terms of prevention. And then there's other frameworks that are more helpful on the intervention side. In terms of understanding what might work in terms of intervention. But I can't give you the last word. All you can do is nod. We do have to move on.